Now, let's continue discussing some of the anatomy of our heart. And this is a very important aspect. The electrical conduction system. If you recall when we were discussing the different types of muscle that is inside of our body, I had mentioned that cardiac muscle is autorhythmic. This means that our heart muscle has the ability to contract on its own. We can remove it from our body and it will still beat. And this feature makes this that much more important when our patients might be receiving donor hearts for heart replacement surgery. Now, the muscles do need to receive a specific signal to contract, and the electrical system that's outlined in yellow here helps facilitate a uniform contraction of all of the heart muscle. There are specific timings for this process, and I'll explain why these timings are necessary. When you look at a EKG, which is pictured here on the right, we are actually taking a picture of this electrical activity. We'll discuss the EKG in more depth later, but we've all seen it on TV shows, and you've probably read about them or had references toward EKGs. And I just wanted to point out that they keep tabs of the electrical activity of our heart. Now, there is a starting point of the electrical activity. It starts here at this dot where my pointer is at. This is referred to as the sinoatrial node, or SA node, also known as the pacemaker cell. This sets the rate in which our heart beats. And we'll discuss what we would consider normal ranges for heart rates a little later. When we're excited and our heart rate increases, there is nervous system input to tell this node that it needs to beat faster. Or when we're relaxing, there's receptors that receive a signal to press the brakes a little bit and slow down. So having a nervous system input can help us regulate how fast and how slow our heart can go depending on the activity. But again, this can function without those types of inputs. It'll beat right around the same rate without much fluctuation, but you'll still be alive. So the signal originates from the SA node, and we have these cables that come out of here. They kind of encapsulate both of the atria up top. So this sends the signal to both the left and right atria to load their respective ventricles with blood to be pumped out into the systemic or pulmonary circulations. Then here we have this atrioventricular node, or AV node for short. This holds up the signal for just a brief moment in time because we want to allow the ventricles to fill up with an adequate amount of blood. Once it comes out of the AV node, there's this small bundle here. It's referred to the atrioventricular bundle, but it can also be referred to as the bundle of His. And that is probably the most common name that you're actually going to hear. After it passes through the bundle of His, it breaks off into these left and right bundle branches. And they start to encapsulate the ventricles. And as you follow this path down and just follow the black arrows, you get to these tiny little conduction fibers at the ends. And you can see them very prominent on the left side here. These are referred to as Purkinje fibers. And these serve as kind of a netting that surrounds the ventricles even more. And when they receive the electrical signal, the ventricles contract, ejecting blood out either through the aorta or into the pulmonary circulation, so into our pulmonary arteries. Now, it's important, again, to remember that the pacemaker goes through the atria to the AV node where it gets held up for just a moment in time. Then as it passes through, the ventricles contract. This allows these valves in the heart to close up. And it prevents us from creating backflow into the atria and back into the circulation. We don't want this backflow because everything needs to keep moving forward. And if it moves back, then we lose the functionality of our heart.